All right, so I think we'll get started, even though we've got a little bit of a lighter group because of the weather. I think we should still try to stay on time. I apologize ahead of time for my voice. It's pretty weak right now. I'll try to do my best to introduce today's seminar speaker, Dr. Wyatt from the Vancouver Prostate Center. Alex obtained his bachelor's degree at University of Nottingham in the UK, and then his PhD degree at University of Oxford in the UK in 2010. He then moved to Vancouver to do a postdoctoral fellowship at the Vancouver Prostate Center. And that's where I first met Alex, when I was there as a visiting speaker, and he was a postdoctoral fellow, and we had lunch together, and I could tell at that point that this guy was going to be a superstar in the field. He was very serious, had lots of great questions and lots of excellent insights to the biology of prostate cancer and the biology of prostate cancer progression. So in 2015, Alex embarked on his independent career, staying at the Vancouver Prostate Center, and has really become an expert in the genomics of circulating tumor, circulating cell-free DNA, and harnessing the power of that tissue or that biomarker to understand disease evolution of prostate cancer, genomic evolution of prostate cancer genomes, and trying to understand how therapies change these various trajectories. So since becoming an assistant professor in 2015, Alex has become exceptionally well funded from all of the major Canadian funding agencies, and he's also received several awards. I just wanted to name those really quickly. So in 2016, he was named a Movember Rising Star in Prostate Cancer Research by Prostate Cancer Canada. And then in 2018, he received the Outstanding Academic Performance Award from the University of British Columbia. And in 2017, he received the CIHR Early Career Investigator Award. So Alex is on a great trajectory from a research standpoint. It's really my pleasure to welcome him here as our speaker today. Thank you.
Thanks, Scott. So yeah, as Scott mentioned, I sort of come from a biology background originally. Actually, my training was in human genetics. My PhD training was in human genetics, and I sort of evolved towards cancer over time. And as I did my postdoc and now into my faculty position, have ended up becoming technically a bioinformatician, although my own capabilities are far outstripped by many of the graduate students in my lab. But most of what we do is on that genomics and bioinformatics side. And I'm very lucky to have a series of clinical mentors, and I work probably more closely with clinicians than I do with other basic scientists, for better or for worse. And so I'm sort of focused very much on some of the questions that are relevant in the clinic at the moment. And what we study in particular is metastatic prostate cancer. And so metastatic prostate cancer, you can get there two ways. You can recur from a localized disease, original diagnosis, or you can walk into the clinic with metastatic disease. And it doesn't really matter how you get there. The treatment is pretty much the same. The mainstay of treating metastatic prostate cancer is to hit the androgen receptor. So traditionally that was done through androgen deprivation therapy, castration, and it invariably leads to what we call castration-resistant prostate cancer, CRPC. And in that setting, again, we hit the tumors with drugs that target the androgen receptor. We also use chemotherapies. We use a variety of other systemic therapies. But as time goes on, the response rates drop, the duration of benefit reduces, and of course, and this eventually leads in death. Over the last few years, there's been a shifting of this landscape, and to some extent a migration of therapies earlier in disease. We're looking at a landscape that's shaped now by combination therapy in this early setting, sometimes maximal intensive therapies hitting the androgen receptor in multiple ways, introducing chemotherapies. But the same sort of problems persist. We have no idea of the optimal therapy and the sequence of therapies for patients. We don't know how to maximize response rates and maximize benefit when we have these multiple toolkits in our arsenal. So where my lab sits is trying to see if molecular subtype, particularly at the DNA level, can help guide any of these decisions here, or whether it's completely incidental. So the last decade has brought a series of new opportunities. There have been a series of large tissue biopsy programs, either leveraging autopsy specimens or actually physically biopsying patients with metastatic disease. And they've shown us a series of kind of overall findings. Firstly, prostate cancer is a structural rearrangement and copy number driven cancer. It's not mutation driven like a lot of other solid tumors. Mutation rates are actually remarkably low outside of a few key tumor suppressor genes. The androgen receptor itself is heavily augmented in resistant disease. So I've listed amplifications and mutations, but there are a series of other changes that can augment the AR in probably upwards of 80-90% of patients overall. And this is reflecting the resistance that's emerging in response to hitting the androgen receptor axis. This is a sort of therapy resistance mechanism. We also know that defects to DNA repair genes, particularly BRCA2, ATM, and CDK12, are prevalent in the metastatic prostate cancer setting. And this has important prognostic ramifications and also predictive ramifications for therapies that take advantage of defective DNA repair. PARP inhibitors, platinum-based therapies, immunotherapies. I'll touch on these later today. But ultimately what this means is that you can actually group metastatic prostate cancer into distinct molecular subtypes based on this landscape, based on a combination of driver gene alterations. And so from our point of view, we really want to understand, does that have any bearing? Do these subgroups have any bearing on the landscape I showed you before, on the treatment landscape? I'll give you a couple of examples of the type of things we look at. So when one studies localized prostate cancer, there are a lot of the same changes you can detect, it's just they're massively enriched when we get to the later stage. Some of the sort of early events like ETS fusion genes, SPOC mutations, those are fairly well conserved between localized and late stage disease. But the more tumor suppressors you build up, P53, P10, everyone will be aware of, androgen receptor, DNA repair gene alterations. You can think of this sort of migration shift almost. The later you look in disease, the more of these types of bad events you'll see. And this kind of fits with our understanding of cancer in general. You know, if you only have a few tumor suppressor hits, perhaps you've got a better cancer than the one that has 20. The problem, of course, is that to study this, historically you've needed to go and get tissue biopsies from the bone of an old man who's already sick, or you've needed to rely on the generosity of men that are donating their bodies to rapid autopsy programs. We have neither of those programs in Vancouver, so we turn to the liquid biopsy. So you'll all be aware this is not a new concept. This is actually a really cool paper from 150 years ago. There was a French pathologist who should be credited with the first observation of the liquid biopsy. He noticed that in a patient that he had that had died of cancer, he noticed that there were cells in the blood that looked really, really similar to the cells he was looking at in a piece of their cancer tissue. And so he was the first person we think observed CTCs in the literature. So fast forward 150 years, we're still not really using CTCs as well as we could be, but I think circulating tumor DNA has come to the forefront in the last few years. And so I'm going to talk for the next 10 minutes a little bit about what ctDNA is, the technical challenges for detecting it and characterizing it, and how we're trying to solve those in prostate cancer. So cell-free DNA is shed by normal cells. So we all have cell-free DNA in our bloodstream. It's it's rapidly turned over. The half-life's about 15 minutes. It's cleared by exo and endonucleases in your bloodstream. It's cleared by the livers and the kidneys. But cancer cells are also shedding cell-free DNA via apoptosis. So when one sequences the cell-free DNA that you get from blood, you can identify potential ctDNA via the detection of somatic alterations, just like you would from the sequencing of tumor tissue. And I'll come back to this because, of course, it's not as simple as it sounds. But what we've learned is, in somewhat luckily, is that the amount of circulating tumor DNA in a patient with metastatic progressive prostate cancer is remarkably high on average. So the median is somewhere between 20 and 30%. But that belays a huge range. And we actually have some patients where almost 100% of their cell-free DNA is tumor-derived. These would be patients with really explosive disease, with visceral metastases, tend to be very sick. But those guys, you will get more tissue from a liquid biopsy more DNA from a liquid biopsy than you may get from a tissue biopsy. But there is the other end of the spectrum where you have patients with lower burdens of disease that may give vanishingly rare amounts of circulating tumor DNA in their blood. But ultimately, this was very lucky for our research because it meant we could actually rely on a blood-based biopsy potentially to inform upon the tumor themselves. So I like to think about this continuum that where you have sort of the best patients and the worst patients, you sort of one can think that ctDNA is preferentially going to give information on the worst patients. And this is an important caveat to remember when you might think that a tissue biopsy is potentially slightly more agnostic to this prognostic spectrum. So this can affect those outcome analyses later on. So I always want people to bear that in mind as we move forward. And that is no more highlighted than in this slide. So this is two of our studies where these are both randomized phase 2 trials, and we just look simply at how much circulating tumor DNA you have prior to entering the study and how that relates to overall survival. And you can see in both of these studies, which represent together about 300 patients, the patients with the highest amount of ctDNA in their blood do much worse than those with lower amounts of ctDNA in their blood. And that's confirming a sort of overall prognosis and an overall sort of what we think is a measure of tumor burden, basically, proliferative tumor burden. So it won't surprise you to know that ctDNA fraction associates with metastatic burden by imaging. So with patients with liver metastases having more than a patient with a solitary lymph node metastasis. It probably won't surprise you to learn that ctDNA fraction, that proportion of ctDNA in the blood, is associated with the typical sort of biomarkers that you'd use to measure metastatic burden in patients with prostate cancer. So blood LDH and ALP, PSA to a certain extent. You can find positive correlations with these, and there's actually a nice paper from Victor Adelstein and Atish Chowdhury that did a great job of summarizing this recently, and if you want to read more, you can look at the relationship with some of these variables. We kind of tried this cool exercise, well, I think it's cool, perhaps not, exercise recently that was to say, well, given that we know that ctDNA is so closely related to sort of what we're seeing in a patient, can we actually flip things around and say, we can predict which patients will have informative liquid biopsies or not prior to actually collecting a blood tube even. So we combined all the metrics that we have and we developed a multivariate model and actually found that we can predict how much ctDNA you have with an error of only 10%. And so we're rolling this out in a couple of our prospective trials that prior to screening a patient, we sort of see how much ctDNA we think they'd have. And if you want to try it out, this is actually a website, ctDNA.org, which we're fleshing out with other stuff, but you can enter in characteristics of your favorite patient and find out how much ctDNA they might have. And we think this kind of thing might be useful for optimizing the use of a liquid biopsy in future. So that's what I've been talking about just in terms of ctDNA abundance was in the metastatic CRPC space. And we did as a, for a couple of slides, I just want to mention the treatment-naïve state, because there was a bit unknown about whether this scenario was the same when a patient's walking through the door. And there are a few caveats here, because a patient that's presenting with de novo metastatic disease is not always managed in the same way that a patient with established metastatic disease might be. They might present in the ER, they might have been given systemic therapy by their family doctor. There's all sorts of complicating reasons here. So we studied, this was published last month, we studied about 50 patients that walked into our clinic with de novo metastatic disease. And by and large, we saw the same sort of spectrum of ctDNA fractions that we'd see in a later stage patient. But importantly, there were 18 patients that had a few days of ADT before we collected cfDNA. And in those patients, we saw significantly lower circulating tumor DNA. And here's 3 that were collected just within the first week. And so you can see this dramatic decline in just 1 week on systemic therapy in circulating tumor DNA. And this was a real lesson to us because this speaks to the importance of timing the liquid biopsy collection. You know, if you miss that window by just a couple of days, you're looking at 1 or 2% circulating tumor DNA to study rather than 80, 40, 50%. And so that's really critical for understanding this disease, and you miss that window, you make life much, much harder for yourself. So I mentioned earlier this concept that how do you know what is tumor-derived? How do you know what signal in the blood is telling you about prostate cancer? And so this is a busy slide, and it's sort of to illustrate the methodology that we take. The critical part to read is that no matter what you do, there's a trade-off here. And that trade-off's between the cost that you're willing to spend, the amount of the genome that you want to survey, and the sensitivity and that you want at that region. So you could do whole genome to 10,000x and to be able to detect everything, but of course that's going to be extremely expensive. So most approaches end up using some form of targeted sequencing. And we actually use sort of an initial like triage panel, so to speak, that gives us how much circulating tumor DNA a patient has. And then we have a series of secondary approaches that leverage, that are sort of tailored to those different fractions. So a patient with 1% ctDNA goes towards a different screening path than the patient with 80%. There are some other tricks of the trade which help a lot. There are non-coding regions that are altered only in the prostate cancer genome. So if we see alterations, this is one particular example, in a gene called FOXA1, we see non-coding 3' UTR mutations. These only arise in prostate cancer. So straight away you can say with very high confidence, this somatic mutation came from a cell in the prostate lineage. And there are several examples like this that can help you be sure that when you identify a suite of alterations, that those alterations are representative of a prostate cancer cell. But let's not forget, we're looking at an elderly population, potentially with other secondary malignancies, potentially with other somatic expansions in their body. So related to that, this might seem like an obvious point, but it's critical to filter out events that are related to clonal hematopoiesis. So there was a study, as an example, last year in JAMA that showed that about 5% of patients that they studied would have at least one clonal hematopoiesis mutation erroneously attributed to their cancer if you just did cell-free DNA-only sequencing. And this was in a small targeted panel. And I would say, in our experience, it's actually considerably higher than that. So probably 10 to 20% of the men we look at will have some low-level variants in their cell-free DNA that you can also detect in the matched white blood cell population. So there are plenty of commercial assays, for example, that do not screen any kind of germline control, let alone a white blood cell control. And so you really run the risk of over-interpreting what you detect there. And you must also be confident of metastatic prostate cancer origin. And I know that sounds a bit strange, but I'm going to give you 2 examples to just illustrate this point. So here we have a case. This is a metastatic prostate cancer patient. He's got CRPC, so he's resistant to androgen deprivation therapy. He's about to receive abiraterone. And so we're literally just looking now at the mutations that we could detect. So I'm not showing copy number profile, which was actually fairly consistent with prostate cancer anyway. But we can see a beta-catenin mutation, a FOXA1 mutation, and together this is an extremely unusual combination to have in any other cancer other than prostate. And at progression on abiraterone, we see the emergence of a mutation in the androgen receptor that's linked to resistance to abiraterone. It's actually via conversion of prednisone to an agonist. But we can be fairly confident in this case that what we're seeing in the bloodstream is representative, at least of a prostate lineage. So I'll give you an alternative example, and this is a patient from the same study, about to receive abiraterone. Again, we see a FOXA1 mutation, a p53 missense, an ARID1A stop gain, and a copy number profile that was very reminiscent of prostate cancer. So we're fairly confident prior to therapy that this patient has prostate cancer liquid biopsy. At progression, we got really excited because we see this huge switch. Wow, this seems like a hypermutated phenotype. We're seeing P53 mutation again, but it's different ones than if you saw at baseline. And we're seeing a bunch of other alterations. A week later, this patient turns up in the clinic with blood in his urine, and a scan and a biopsy revealed metastatic bladder cancer. So what we originally thought was progression event on his abiraterone was in fact another cancer popping up. And so without due diligence, you might kind of come to some conclusions about this profile that would be incorrect. And I wish this was a really rare story, but the reality is that we have to put this diligence on every patient we look at in the study, and you have to maintain that relationship with the treating physicians to understand exactly what's going on in their patient each time you take a collection. And it extends not just to other cancer diagnoses, but if they have an infection or even a cold at the time they come in, that's going to affect the ctDNA fractions that you detect and so forth. So with all those caveats, I would point out that the approach that we use, we've had the luxury of refining this over the last few years and trying to take into account as many of those variables as possible, although inevitably we are still not perfect. But we do see very high concordance between circulating tumor DNA and matched tissue when we pair them at the same time. And this was a study from JNCI a couple of years ago where we profiled matched metastatic tissue biopsy and ctDNA and found very good concordance both for copy number changes and mutations. Scott Tomlin's group has published similar observations using a different approach, and that's a good reference for you if you're interested. We've also looked in the diagnostic setting when a patient's diagnosed with metastatic prostate cancer. And again, in this setting, looking at the prostate biopsy and the circulating tumor DNA, which may actually reflect slightly different components in this setting. But again, we see pretty good concordance, although I would note in this setting that there's a potential for combination of the two approaches, since there are some alterations that are picked up by either tissue or ctDNA alone. But overall, this gives us confidence that what we see when we apply our approach to patients where we don't have tissue biopsy is representative of the metastatic tissue. And so that's critical for going forward and then trying to correlate with clinical outcomes. I'm going to show you two slides on what not to do, but with perhaps the best of intentions, but we have tested some of the existing commercial assays. And to say a positive thing, I think they are adequate for mutation calling at high allele frequency. So in this case that I'm showing, we subjected 24 patients to parallel profiling by our sort of academic approach and by Guardant 360, which is a commercial approach that just sequences cell-free DNA. So we were actually able to independently confirm almost all of the mutations that they reported at high allele fraction. So although there were some that they missed, including an ATM stop gain in 2 different patients. But at low allele fractions, most of what Guardant was reporting were related to somatic clones that were clearly not prostate. So some were clonal hematopoiesis, others we think are just other somatic expansions in the body that are present at low levels in the blood. And so, this reinforced the value of using matched white blood cells, but also of really questioning things when you see extremely rare things in a patient. But critically, the utility of commercial approaches is extremely limited by the lack of reporting on deletions, rearrangements, and the germline. So these are 3 categories which are of critical importance in prostate cancer. As I mentioned earlier, the prostate cancer is a genome of structural rearrangements. So if you're missing these, you're missing a huge amount of potential information. So to our surprise, Guardant did not report several DNA repair gene alterations. So this included germline and somatic BRCA2 mutations, deep deletions in BRCA2, reversion mutations in response to a PARP inhibitor, and even a patient with a mismatch repair defect and hypermutation. So these were all missed and not reported back to the physician. So we're trying to publish this at the moment, but you can imagine that's not the easiest. It's a tightrope to walk here. So, what can we do with all this technology and this this approach? So, we wanted to try to study standardized populations where we thought at least we can make some broader conclusions than we might if we just restricted ourselves to retrospective analyses. So I've been lucky enough to, my clinical mentor is Kim Chi in Vancouver. He's a medical oncologist, and he runs several large trials across Canada, and he's also the chair on some phase 3s globally. So this is one of the trials that we started working on several years ago and has turned out to be a goldmine in terms of data. This was enrolling 200 patients and treating them with either abiraterone or enzalutamide. So these are two drugs which work fairly similarly from a sort of macro level in the sense that they both target the androgen receptor signaling axis in patients that have already developed castration-resistant disease. So we know that from the clinical trials where these drugs were shown to have efficacy, that most patients respond pretty well to these inhibitors when they're first used. And it's because there's probably, they're introducing a higher fitness threshold than standard castration is able to do. They're putting more pressure on the androgen receptor and a stronger inhibitory pressure. So we tried to ask what we thought was a fairly simple question of if we know the genomic subtype up front, can we predict in any way the patients that are going to respond well to either of these drugs or poorly? And what had been done before by our own group and others was taking sort of individual genomic things. So looking at something like an androgen receptor gene amplification and saying, does that associate with outcome? So the limitation of that is that you're not placing it in the context of the rest of the genome. You're not placing it very well in context of the patient overall. You know, I understand that a physician will do a pretty good job of guessing how a patient's going to respond just from the prognostic criteria alone. So what we tried to do was set up a couple of multivariate models that allowed us to combine together molecular subtype and prognostic criteria and try to understand, is there anything in here that's giving an independent signal? Something that really stood out above and beyond the standard clinical factors, the standard genomic factors, when you sort of throw them all against each other. So the strongest prognostic effect overall was for p53 alterations, so mutations, deletions, structural rearrangements perturbing p53. And that's probably not a surprising thing. Across many cancers, this is associated with bad outcomes. Probably has fairly little potential as a predictive marker, but it's as a marker for sort of prognostic, for prognosis, it seems to be fairly clear. And this was independent of any clinical variable, of any other genomic variable. And this has actually been validated this year by a group in Antwerp. They published a sort of follow-up paper in Clinical Cancer Research, finding pretty much the same kind of hazard ratio as well. So we were quite happy to see that. So we wanted to explore the androgen receptor in a bit more depth because that's what these drugs are targeting. So perhaps naively, we went in thinking that we're going to see these categoric responses depending on exactly what your molecular subtype is. You're going to respond or you're not going to respond. But I think we ignored the fact that androgen receptor amplification is not a binary variable. It's a continuous variable from very high to lower and absent. And this might create some sort of dose effect, theoretically. But it also represents an average of the ctDNA shedding cells at the time you sampled them. So when we see something that's around 20 copies, it may represent half of the cancer cells that have 40 copies and half that have 1. We don't know. We're seeing an average of all the tumor cells in the ctDNA. But it was interesting to us that if we just sort of look at androgen receptor alone, it's not sufficient to say that a patient won't respond to AR-targeted therapy. Although we do see a hazard ratio of around 2, which is similar to what we and others had published before. So there is certainly, it doesn't mark a good set of patients, but it doesn't preclude response to these therapies. And that makes sense because we know clinically that most patients respond to first-line AR-targeted therapy. So this was sort of a result that made sense. Interestingly, when we started to look at these very high AR gain patients, so these are patients that seem to have 20, 30 copies of the androgen receptor on average in their genomes, we did see the beginnings of a split. So the patients with very high AR gain did seem to do worse than those with lower or absent. So this sort of fits with that hypothesis of maybe a dose effect for the amount of AR that you have. So these were some of the earlier studies that one can look at. We published a couple of these. Gerta Tard's group in London had also seen similar signal, but they were only looking at single gene markers. And so we were also interested in mutations because androgen receptor mutations are another known mechanism of resistance. They arise in about 10% of patients. And Gert's group had reported that a couple of mutations were remarkably strongly associated with overall survival when patients were being treated with abiraterone. So we were kind of expecting to see something similar. But actually we found that in our study, AR mutations were not precluding first-line response. And there's an important caveat here, because the most common mutations that we were seeing were different to what you might see when you study patients later in disease. So we're studying patients fairly early during their disease course. They've only received androgen deprivation therapy. They haven't been hit with a whole range of bottlenecks of different therapies. And the androgen receptor remodels over time. So we were sort of seeing what we call the first generation AR mutations, changes these two mutations here. We didn't actually see any of the alterations that are associated with later stage patients. And so what we actually found was that these patients that have AR mutations, which tend to be mutually exclusive with the amplifications, they actually do pretty well on treatment. So we find no significant association with outcome. And if anything, they actually do better than the average patient. I'll touch very briefly on AR gene structural rearrangements because obviously I think Scott's probably talked to this group before about this aspect. We were very relieved to see that when we do detect rearrangements that truncate the androgen receptor, truncate and remove part of its ligand binding domain, that these patients showed primary resistance to treatments that try to target the ligand binding domain. This was sort of our index case, who had an 11 base pair deletion, which removed exons 5, 6, and part of 7. And we were actually able to PCR the transcript out of whole blood. It was so highly expressed in this patient. And confirmed by a Sanger sequencing that the transcript itself was expressed. And that particular patient had no response to therapy at all and came off trial and died just 2 months later. So he was representative of what we saw in the rest of the cohort in this study at that time. The patients with truncating gene structural rearrangements were more likely to have bad responses to therapy. And so that's a trend we've continued to see since this paper was published. So I'm not going to labour the point too much because I know Scott's probably presented on this topic before. So the next thing we were really interested in the study is, so what we've done so far was just like a single static time point. But of course, the cancer genome is not a static thing. It's in constant flux, constant evolution. It's probably rarely ever monoclonal. You've got a milieu, a heterogeneity of clones at any one time point. So how does the genome evolve in response to therapy? So I'll show you a clinical slide. So this was how this trial looked like from start to finish. So patients receiving first-line abiraterone or enzalutamide, outcomes were pretty much identical between the two. But in the second-line setting, patients were really only responding to second-line enzalutamide and were not getting benefit for second-line abiraterone. But nevertheless, you can see here there's a big mix of responses. There are some patients that are doing very well on second-line enzalutamide and some that are doing very poorly. So we're really trying to understand, well, is there any explanation for why patients might be doing different in this second line, given that clearly most are responding to first line? And so we do have some tantalizing clues to that. So we took the 3 time points that we have here, prior to any treatment, after one progression, after second progression. This is 200 odd patients. And we asked the question, in patients where we have confirmed circulating tumor DNA throughout the study, what's changing? So it won't surprise you to learn that some of those truncal alterations, like a p53 alteration, an SPOT mutation, which is a sort of initiating event in prostate cancer, we don't see any changes in those genes. We detect the same genotype at progression. However, and this is probably a conservative estimate so far, at least 50% of changes have 50% of patients have some kind of change at the androgen receptor gene loci. This was really, it's not massively surprising, but it's really, really encouraging to be able to see this from a liquid biopsy alone. So we saw a loss of gain of AR mutations. There was actually only one patient with AR mutations that had the same genotype at baseline that they did at the end of treatment. So we see sort of this dynamic switching of the mutations. We saw increases in the AR amplification level, so potentially higher number of AR genes in the copies at the time of progression relative to baseline. We were able to detect new genomic breakpoints within AR introns that perhaps were masked to us by their lower prevalence at baseline than at later progression. And we were able to see changes in the AR gene and the enhancer copy number structure. So I'm going to walk you through a few examples of this. Each one is an anecdote, but it's representative of groups of patients. Well, the first thing I'll show you is if you look at the androgen receptor sort of loci on the X chromosome, so we're looking at 20 or so megabases across the X chromosome. If you take the average of the copy number profile from all patients in our study, we see this really neat sort of gradual rise up, peaks around the androgen receptor and declines afterwards. And so, you can really see what the selective pressure is overall. There's this region upstream of the androgen receptor, which has recently been characterized to be a somatic enhancer of the AR. And I think we and basically everyone else in the prostate cancer world kicked ourselves at the same time and go, why on earth did we not notice this before? This curiously broad peak here, and that was quite a surprise. But basically there's an enhancer upstream of the androgen receptor, which seems to be in part required for high AR transcription activity. And in some cases you can even see amplification of the enhancer in the absence of any underlying high AR gain. So I can actually show you an example of that in our studies. This is one patient, the same zoomed out view across the androgen receptor and the X chromosome. And so here you can see there's a few extra copies of the androgen receptor, but there's this region over here that's at a higher level. And zooming in here, this actually represents the AR enhancer. And this is zoomed in on the X chromosome. And this is a patient, you can see a breakpoint towards the end of the ligand binding domain here, deleting exons 4, 5, 6, 7, 8 here. And so this is a patient with AR enhancer amplification, a few extra copies of the AR, and a deletion of the ligand binding domain. So go figure what's causing the resistance or the prognosis in this patient. We can't really parse them all. But it speaks to the heterogeneity and the polyclonal landscape in these patients. So one of the first things we observed was that there were patients where we were detecting higher levels of AR amplification than we'd seen at baseline. And so we thought that, initially that maybe that's a fairly simple explanation. You have a clone, it then acquires a few more copies of the AR, and now it can overcome an AR inhibitor because of a dose effect. But actually it turns out it's not as simple as that. So here we're looking at the same patient that was profiled over the three different time points. And again, this is that region across the X chromosome with the AR in the middle. And so if you have keen eyes, you can see that this overall copy number structure here is actually different between the three time points. So what seems to be a clear breakpoint here is not really evident here. And what seems to be a clear breakpoint here is not really evident here. So this sort of gives you the clue that, well, it's not really as simple as sort of a single clone gaining a few extra copies, that perhaps what we're seeing is the selection out of this milieu of a clone that happens to have a higher level of the androgen receptor. And so that's kind of the hypothesis that we're working on at the moment, that in the wake of androgen deprivation therapy, you have a pool of different metastases potentially that have there's some convergent evolution, but potentially the mechanism by which, the exact underlying mechanism by which they've done that is a little bit different. And in the wake of more potent AR inhibition, you select out the fittest clone. And just to show you this isn't, I'm not cherry picking, here's a second example, similar kind of scenario, a few copies at baseline and a much higher level at progression, but seemingly different breakpoints at baseline, which suggests to us that this was a minor clone in this original sample and has now been selected out. So as you can imagine, this is a very difficult thing to quantify at the level of 200 patients, because each patient is a little bit different, and so this is what basically we're struggling with to do at the moment, and hopefully we'll figure out in the next few months, and maybe you can read about it later this year. And one final slide on this, just to illustrate that we're still surprised by things we see. This is an AR amplification peak in a single patient. And normally what we'd expect is these sort of stepwise changes that are sort of consistent with either with breakage fusion bridge or tandem duplications gradually acquired over time. But we still see cases where we cannot at all parse how something as neat as that happened in a genome that's riddled with rearrangements. And so there are still things we see and go, how on earth did a cell acquire that perfect pyramid? I don't know the answer to that. So the model that we're working with now is that there are different fitness thresholds that are imposed on the androgen receptor by different levels, by different types of inhibitors. So we think that basically, the kind of fitness threshold that's imposed by standard androgen deprivation therapy can be overcome by a few of those first-generation mutations. It can be overcome by a relatively low level of androgen receptor amplification that basically provides you with more transcripts and more protein. But that potentially a higher level of AR amplification gives you a higher dose of the AR gene. And that there are also some mutations that arise after abiraterone that are sufficient to overcome abiraterone, but potentially not enzalutamide. We've also seen that in the wake of enzalutamide, you can acquire multiple mutations in the androgen receptor, and that also seems to be sufficient to overcome that fitness threshold imposed by enzalutamide. And then, of course, we have the LBD truncating rearrangements that can overcome pretty much anything you throw at the ligand binding domain. So at the moment, we're trying to fit our data onto this model, and this is totally unpublished speculation, so please don't quote me on this. It may not turn out to be true, but this is the model we're working on, and there are some caveats thrown in. And ultimately, what we're trying to address is does the mechanism of evolution from here to here then affect your subsequent response to therapy? And if it does, what else could we do any differently? And I'll give you one quick clue. So Gert's lab published late last year an intriguing result, which was that patients with androgen receptor amplification in their hands seem to respond reasonably well to taxane-based chemotherapy. So potentially a chemotherapy that's not further hitting the androgen receptor. And so it's entirely plausible that using a therapy that sort of acts outside the androgen signaling axis may still have efficacy in those patients that have evolved sort of to totally overcome the fitness thresholds imposed by AR inhibitors. So I think there is hope. So in the final part of my talk, the last sort of third or quarter, I'd like to talk about DNA repair gene alterations. So alterations in BRCA2 and other genes that are very prevalent in metastatic prostate cancer and represent a unique therapeutic vulnerability in this setting. So somatic mutations and structural rearrangements to BRCA2, CDK12, ATM, and some mismatch repair genes are pretty common. And so are germline mutations in a couple of these genes. The problem is each gene plays a different role, and they shouldn't necessarily be grouped together. So BRCA2 is clearly an HRR gene, but yet ATM is perhaps more upstream. It's a DNA damage sensor. It phosphorylates p53, for example. It's perhaps potentially more involved in cell cycle checkpoint than it is in DNA repair itself. And furthermore, the actual mutation that you detect in a DNA repair gene is different from patient to patient, and so the nature of the downstream effect is different from patient to patient. So I think too few studies are really understanding the wider genomic and clinical context of each mutation that's identified, and we're sort of erroneously grouping things together and trying to study outcomes when really these patients are not the same, and the underlying effects that's caused by these mutations is not the same from patient to patient. One thing we do know is that a BRCA2 truncating mutation is associated with poor prognosis pretty much across the disease spectrum with standard of care approaches. So in the localized setting, a germline BRCA2 mutation confers poor prognosis in pretty much any clinical scenario that you examine in prostate cancer, and that seems to be the case in prostate cancer too. In one of our poor prognosis cohorts, we found that 30% of patients have a DNA repair defect. In the setting of de novo metastatic disease, which represents really one of the worst phenotypes from a metastatic point of view, these mutations were enriched in de novo metastatic disease. And in our hands, we've seen poor responses to standard of care systemic therapies in CRPC in patients with BRCA2 altering truncating mutations. Now, this has not been borne out by some other studies, and I think part of that is explained by the criteria I touched on earlier, and also explained by the differing ways in which patients are handled from center to center. I think diagnosis time is of critical importance, and if you're enrolling predominantly patients that are diagnosed in rural British Columbia, they may be at a later stage than those at a high-volume cancer center somewhere else. If you're using platinum-based chemotherapy routinely, you're also going to change the natural history of these tumors and potentially home in on some of their vulnerabilities, as you may not also see that prognostic trend. But nevertheless, in our hands at least, this particular gene seems to have a poor prognostic effect, at least for standard of care therapies. But the cool thing is these alterations can be exploited. So here's an example from our clinic of a patient with an extremely nasty form of metastatic prostate cancer. It was actually small cell cancer. He's got metastases in his liver, large lymph node metastases. This patient had a homozygous BRCA2 deletion in his liquid biopsy. So we gave him, Kim gave him platinum-based chemotherapy, and he had an exquisite response to that. And this was in 2015. He had brain metastases, and he went on to olaparib, and it's now 3 years later, and he has no evidence of disease. So this is an unusual patient, potentially very difficult for this patient to develop resistance because he has no BRCA2 at all, but these do exist. And we've actually seen this phenomena in a few other small cell prostate cancer patients. Those that have responded best in our hands to platinum-based chemotherapy seem to have underlying BRCA2 defects. So, of course, there's the famous New England Journal paper from Johan de Bono's group that showed that olaparib is effective in a proportion of metastatic prostate cancer, and that proportion seems to be the 20 to 30% that have DNA repair defects. But, of course, I think really understanding the exact nature of that DNA repair defect is going to be critical for segmenting that population to those that respond and not. And one thing I would mention is that, unfortunately, even in the patients that do respond to PARP inhibitors, resistance is going to emerge. And so we and others have published on reversion mutations arising, both being detectable in the cell-free DNA and also in tissue mutations. So this is alterations that restore the reading frame across a BRCA2 stop gain. So they're all in multiples of 3, and they restore the reading frame. And so what you end up with is basically a functional BRCA2 gene in the tumor again. And because I'm here in Minnesota, this is a patient from Charles Ryan and Felix Feng's group, sort of collaborating together. An example of a BRCA2 reversion mutation and a sort of remarkably heterogeneous one that we found after PARP inhibitor resistance a bunch of the sort of typical read frame restoring alterations, but also a case, a scarcely believable scenario where pieces of chromosome 18 were inserted into one of the exons of BRCA2, forming a perfect multiple of 3 and restoring reading frame, presumably of BRCA2. So a sort of case where the cancer cell has taken some junk from somewhere else in the genome and used that to restore BRCA2 function. I sent that to my student when he sent it to me originally. He said, this is how it works. So the last couple of slides, I just want to mention hypermutation and mismatch repair defects, which is, I guess, the final category of DNA repair gene alterations that seem to have therapeutic implications in prostate cancer. So mismatch repair defects can be robustly detected in circulating tumor DNA, so they lead to a very high tumor mutational burden. And the preliminary data coming out of course, pan cancers in general, but for prostate cancer coming from Memorial, seems to suggest that some of these patients with mismatch repair defects are responding to immune checkpoint blockade. Unfortunately, it represents only about 3% of cases, at least in this study. So it's a small segment of the population. So it's one of these scenarios where we clearly need a practical biomarker to be able to detect. So in our hands, and this was a data freeze representing about 700 CRPC patients, we can detect mismatch repair defects and hypermutation in 3.5% of patients with the liquid biopsy. And so that fits with what you just saw from the tissue-based study. But what I found particularly exciting here was that even in the patients where you can't actually detect that underlying MSH2 alteration, you can see the scars of mismatch repair defect at the genome level. So you can find a suspected mismatch repair defect by a high mutation burden, a trinucleotide signature of mismatch repair, and an unstable microsatellite signature. So I think we're moving towards the genome being a biomarker rather than just the specific underlying mutation, which is important. As this was sort of the model we have to move towards, where small subsets of patients responding to these therapies. So my conclusions overall, my sort of final considerations, is the caveat on everything I've said, basically. So with plasma cell-free DNA, all your patients are eligible for a biopsy. With a tissue biopsy, clearly that's not the case. And so I think of this continuum where liquid biopsy is kind of giving you a bias towards the patients with the worst prognosis. But a tissue biopsy is maybe missing some of the patients clearly without radiographic disease, just like ctDNA does. And it's also sometimes struggling to capture those patients with really rapid deterioration where it's not really appropriate to subject them to a tissue biopsy, or they're deteriorating so rapidly that it's just not reasonable. So I think this difference between the landscape that you'll get from a liquid biopsy and a tissue biopsy is going to continue to dog the fields. So clearly cell-free DNA provides no tumor information in some patients, but I think, as I mentioned, the tissue biopsy also fails to capture tumor tissue in some patients. And an advantage of cell-free DNA is it obviously captures information from more than one lesion, whereas tissue biopsy informs on only a single lesion. But I actually view that sometimes as a weakness, because what we see in the liquid biopsy is a homogenization of all that heterogeneity. And so we're not able to get that high resolution dissection of a single clone that you can get when you study one metastatic lesion. And finally, this should go without saying, but I'm going to say it just in case, we only study DNA. And there's a lot more to these tumors than DNA. And so we're missing all of that. So my final slide is a plug for one of our prospective trials where we're now trying to use this information moving forward. And so we've so far enrolled 129 patients on this umbrella trial, which we're hoping to grow out to 14 different agents over time, where we're using the approach I've outlined to stratify patients onto biomarker positive or randomized to biomarker negative arms. So we hope that this is going to show some signal and sort of help underlie the potential utility here. Okay, so thanks to everybody in my group. In particular, I have one brilliant student, Matty, who's far more brilliant than anything I could ever do, and so he's responsible for a lot of the work done in the lab. And of course, Kim, any of you that know him, he's an incredibly generous man with his time. He's the best mentor I could hope for, and he's sort of as well had a hand in everything that's up here. So, thank you, everybody.
Yeah, so my question regards the possible mutations related to this, and especially the next to the last slide that you presented. So a lot of the timing for using this method as a possible method to quantitate the circulating tumor DNA is based on the assumption that everything that we see is actually coming from the tumor cell. However, during therapy, a lot of the circulating tumor DNA may be actually produced from other cells, like white blood cells and histiocytes. They can store a lot of this circulating tumor DNA. So a lot of what you get in terms of heterogeneity will actually not reflect exactly what the tumor cells at that particular point in time carry.
So, I mean, you're entirely correct. So every patient has normal cell-free DNA, and most of that is derived from the hematopoietic lineage. Most of the time, that DNA contains no somatic alterations. So, you know, when one filters out the white blood cell, when one uses the white blood cells to filter things out, you shouldn't see anything that was present also in the white blood cells. So we're looking at somatic changes. But in a lot of these patients, there are low-level somatic changes in the hematopoietic lineage too. So as I mentioned at the start of the talk, that's a critical part of this pipeline is being sure that the somatic alterations you detect are prostate cancer derived. And so, yeah, that's a good point.
We know that prostate cancer in African Americans is a particularly aggressive type of cancer. In your studies in Canada, have you noted any ethnic variations in your prognoses?
So the BC population is mostly people of European ancestry and also people of Asian ancestry. We don't have many of African descent.
Yeah,
so
how about the Asians versus the European?
Yeah, it's a good question. It's something we're just beginning to touch on at the moment. It's very difficult for us. So self-reported ancestry doesn't seem to be, you know, to do that well for us. You know, we can't be so sure of things. But so we're trying to use a sort of actually a genotype approach based on our data to segregate by ethnicity. But I'd say it's too early to say. But that, you know, it's certainly an avenue of interest for us.
Question. So has your lab or any of your collaborators or for prostate gang that's here, anybody in the field actually cloned out any of these BRCA2 reversion mutations and actually proved that they are expressed, stable, and functional along with the combination DNA repair, particularly those that are kind of far-fetched, like the one you showed?
Yeah, I know.
18, just because it's back in frame, I mean, if the BRC repeats aren't put back into place, if it still doesn't restore some of the important phosphorylation sites for regulation, if it doesn't bind RAD51, just because it's in frame doesn't actually prove anything.
Correct. So I agree with you that, you know, sometimes we'll see 10, 20 alterations, and yeah, there's absolutely no guarantee that 18 or 19 of them are doing anything.
We'll chat further about it, because we're doing the same thing on ovarian cancer.
Yeah.
We're
So
running at the same time.
so I think so Alan Ashworth's group I think is doing some work in this, but potentially not in prostate.
I think they've shown some of it.
Yeah. The other thing we're really interested in is whether there are some regions of BRCA2 that can't get reversion mutations, basically,
Right.
because of this context that you're talking about. So exactly. So we suspect those patients might be more sensitive to PARP inhibitors and platinum than some of the others. Yeah. So there was a question over there. Yeah.
So when you have a DNA return, especially with say a BRCA, is it usually exclusive with other DNA repair genes that work within that same part of that pathway?
Mm-hmm. The answer is yes, pretty much. But the problem is the numbers that you have, so sort of 5% to 10% that have each of these. It's hard. You need a very large data set to be sure of mutual exclusivity. But so far, it seems to be the case that you sort of head down one path or the other. The other thing is that the sort of three most common genes, BRCA2, CDK12, and ATM, the genome sort of scarring is quite different that you see between those 3 genes. So the actual, I suppose, the effects that's enabled by their loss is different between these cancers. Very distinct, actually.
Sorry to ask the second question related to that. Can you see those scars at the exome level versus the genome level? Versus, I mean, like how small of a panel can you use and still see some of those signatures?
So for CDK12, it's very easy to see there's a characteristic tandem duplication signature, so you can absolutely see that at the genome level. I'd say for BRCA2, it's more challenging. We use, one of our panels pulls down a lot of intronic regions, and that's often where the breakpoints are falling for those microhomology mediated the signatures that you need for that. Yeah. So, I mean, you can use. I mean, it does work at the exome level with some of those cosmic trinucleotide signatures as well. But yeah, ideally you would want whole genome to elucidate that.
Okay, we have a CAP inspection team meeting in about a minute.
Yeah, so thanks Alex for a great talk.